It gives me immense pleasure to introduce Dr. Neil Bressler, our next panelist, who absolutely needs no introduction. He is the man behind all the diabetic retinopathy clinical research network protocols that are followed across the world. He's on the chair of the trials related to diabetes like the DRCR.net, National Eye Institute, and multiple FDA trials. Dr. Bressler is currently the editor-in-chief of JAMA Ophthalmology. His expertise solely lies in diabetic retinopathy and macular degeneration. I've had the absolute pleasure of doing my retina fellowship under him. That 1 year with him was my absolute favorite as I got to learn so much from him. We have the honor to have Dr. Neil Bressler speak on the clinical trials of managing diabetic retinopathy. Welcome, sir. Thank you for being a part of our show.
Well, thank you, Pooja. Dr. Pooja has been my wonderful connection with the up-and-coming ophthalmologists in India. It's just a pleasure, and it's a pleasure to always interact with all my colleagues there. I wish you all well. The pandemic that has gone on is always our first priority, and we feel for everyone that has had challenges from this. We understand that it's not over. We have a lot of work to do, but at the same time, we still have to take care of people with diabetes that affects their eyes, and we're still working on ways of trying to improve the care. Since I've been there, we've had a lot of new studies come out or analyses of other studies, and I thought I'd spend about 30 minutes or so talking about what we've learned and how we approach diabetic retinopathy, and then maybe 15 minutes for some questions along the way. So I'm going to share my screen. And I'll go through where we are with all of this, and just let me know if you can indeed see the slides there. Yes, Pooja?
Yes, sir, we can.
Okay, good. There might be a slight delay as I go forward. It has to go just a little across a few oceans here to get to you all. These are my financial disclosures. We have grants from industry to the university to help support the research efforts that we're doing. I wanted to present how the data influence our current management of diabetic macular edema. And first and foremost to say, we actually base our decision on the visual acuity when the person walks in. We don't base it on what their OCT looks like. We don't base it on their hemoglobin A1C. We don't base it on their diabetic retinopathy severity scale. We don't base it on their high blood pressure. We don't base it on if they're type 1 or type 2. We keep it simple. We base the management on their visual acuity. Now, this first started about 6 years ago. In 2015, the DRCR Network looked at 3 different agents for treating diabetic macular edema. And they reported that the decision-making is different if the vision were 2032 to 2040, or if the vision were 2050 or worse. When the vision was 2032 to 2040, treatment led to improvement. So you still treated people, even though the vision was relatively good. On average, there was a 7 or 8 letter gain. That's the average. Behind that average, some people had no gain. They were all 2032 to 2040 to begin with, so if they had no gain, they still did pretty well. But some people gained 2 lines, maybe to 2020, maybe to 2016. But the average was that everyone gained about, on average, 1.5 lines for the whole group. But I'll show you how this is clinically relevant in some future slides. It didn't matter, though, which agent you used, whether you used aflibercept, bevacizumab, or ranibizumab. We couldn't find on average a difference between all 3, so you could choose either one that you have access to. We also learned for the half of the cohort that were 2050 or worse, it did make a difference which agent you would take out of the refrigerator. It doesn't mean you have access to all 3. If you only had access to bevacizumab in blue, that works very well. That has a substantial gain on average. It's just not as good if you were able to take aflibercept out of the refrigerator. This gave, on average, gains that were definitively different from the ranibizumab group in yellow or the bevacizumab group in blue at 1 year. Now, at 2 years, it was still definitively better than bevacizumab, but not necessarily ranibizumab. And we'll come back to that disconnect at 2 years versus the results at 1 year. But I want to start with this table that was in the 2-year outcome. These are 2-year outcomes for the cohort that started 2032 to 2040. So they started with good vision. It was about half of the group. You can see it's about 300 people given either aflibercept, bevacizumab, ranibizumab. And I want to look at how many people, what was the percentage that ended up 20, 25 or better? That's really good vision. And the percentage was about 70%. So I didn't tell you what the regimen was. I just said that in this group that started 2032 to 2040, following the regimen that I'll describe, about 70% were 2025 or better. Now, if you walked in 2050 or worse, you still have improvement, but now only about 45% are 2025 or better. So this told us not only does the baseline vision determine whether we have to consider different anti-VEGF agents, but the baseline vision tells you how many people will end up 2025 or better. If you can get a monitoring system where you catch the person just when they're 2032 to 2040, 70% end up 2025 or better. If your system doesn't pick them up until they're 2050 or worse, it's still better to treat with anti-VEGF than laser, but only 45% end up 2025 or better, a big difference. You'd rather catch them, if you can, at 2032 to 2040. Now let's go to this concept. We said when they're 2050 or worse, aflibercept was superior to bevacizumab or ranibizumab at 1 year, but for ranibizumab, not at 2 years. Why would we still start with aflibercept if they're 2050 or worse? Why not ranibizumab? Because over 2 years, the time spent with improved vision, the area under the curve with improved vision is greater with aflibercept than ranibizumab, okay? So let's go into what we see for the area under the curve. What we see here is for the area under the curve in orange, it's superior to use aflibercept than either ranibizumab, the area under the curve in yellow, or bevacizumab, the area under the curve in blue. And that's over 2 years. And that's because when you start at 2050 or worse with aflibercept, you don't close your eyes and then open them at 2 years. Or you don't start with ranibizumab and close your eyes and open them at 2 years and the vision's the same. Yes, it is. But your eyes are open at 1 month, at 2 months, at 6 months, at 1 year, and over that first year. There's more time spent with improved vision when looking at the average vision of the 3 groups. Now that's just the average vision. That's for the groups. But we then typically look at clinically relevant outcomes that go behind that average. For example, we look at the percentage of people that end up 15 or more letters better. And we choose that because there's 5 letters on each line of these charts, and every 3 lines or every 15 letters, the letters are half the size. Now, what we do is when we have people that are 3 or more lines better, they can read better. They have much better vision. And so that's a clinically relevant outcome behind the average changes. And what we can see here is that when the baseline visual acuity is 20/50 or worse, you're more likely to have 3 or more line gain at 1 year if you had started with aflibercept than ranibizumab or bevacizumab. 40% with bevacizumab gain 3 or more lines. That's great, but not 67%. And so you don't know how the individual is going to do. We cannot predict beyond the baseline visual acuity what affects the outcome. Now, this looks at 2 years. There is no difference. That doesn't mean you shouldn't start with aflibercept if you have access to it, because over 2 years, these data tell us you're going to spend more time, 3 or more lines better over 2 years if you start with aflibercept when your vision is 20/50 or worse. Again, I haven't gotten into what the regimen was to get these outcomes, so I want to go over that now. The objective was to try to maximize visual acuity, but maybe minimize the number of injections or visits. So we started with 6 monthly injections. We kept it simple. There was one exception. If you were 20/20 or better and the OCT appeared normal for 2 consecutive injections, you could withhold injections in the first 6 months. But 95% of the people in the first 6 months are not 20/20 or better and have a normal OCT for 2 consecutive injections. So most of the time, you want to educate the patient to say, I want you to end up 20/25 or better. We're going to start with 6 monthly injections. Thereafter, Not forever, monthly. The first 6 months, 6 monthly injections. Thereafter, we're only going to treat that person if they're still improving. Improvement trumps everything. If they're not still improving, then we're going to withhold treatment. If they're stable, even if they're thickened, if they're stable beyond 6 months, we don't have evidence that it's worth continuing to treat these people. The lines level out and they don't decline when we withhold treatment. And when you compare this to, for example, industry-sponsored trials by Vivid and Vista, when they're given monthly treatments, there isn't greater improvement beyond what's seen with this as-needed regimen. This is not a treat and extend regimen. This is monthly monitoring in the first year and treat as needed beyond 6 months, only if they're improving or if they're worsening. And if you withhold treatment, then you would resume treatment if they start to worsen. And in the second year, if they're stable, we would double the follow-up, not to monthly, but to every 2 months. And if they're still stable and we're not treating, we would double the follow-up to 4 months until the edema comes back or the vision worsens, and then we resume treatment. Now, improvement or worsening is defined for vision and OCT. For vision, it's defined as changing 1 or more lines, 5 or more letters on the chart. And for thickening, it's described based on the central subfield thickness, not the cystoid abnormalities, not the subretinal fluid. You can look at those to see if the internal limiting membrane to the pigment epithelium was identified correctly by the automated algorithms in the machine. But if they find it, we don't look at the morphology, we look at the number. And if the number changes by 10% or more, that's probably a real change. So going from 400 to 360 is at least a 10% change. Or going from 350 up to 385 is probably a real change. Now, why do we start with 6 monthly doses? We do that because after the first dose, about 30% of the people no longer have thickening beyond 300 microns. 70% are still thickened beyond 300 microns, but 30% are not. And even in that 30% that are no longer thickened beyond 300 microns, they might still decrease. But with 2 and 3 injections, the percentage beyond 300 microns begins to go down. But we don't stop there because with 4, 5, and 6, the percentage beyond 300 microns continues to go down. So with anti-VEGF, we see continued improvement anatomically, not after 3 injections. That's what many people say, oh, I'll start with 3. But there's no scientific evidence that you should do anything but start with 6. There's one exception, as I said, but it applies to very few people. So typically, start with 6 injections, but not just because of the OCT. There isn't a good correlation of the OCT with visual acuity. If you look here, you can see that with the aflibercept, the vision improves on average for the group to about 10 letters, but with 3 more injections, it's up to a 13-letter gain. That's the average for the group, not just one individual, but the average for the group. That's a real change. Now, we don't look at the OCT to determine if it tells us how good the person is doing. The OCT only tells us, do we have to resume treatment? So it guides our management, but it does not determine if we're going to treat people. Or I'm sorry, it does not determine if the person is doing well. So what we see here is when we looked at the Vivid and Vista data, and these are some data that Dr. Susan Bressler presented at the Macula Society, when she concentrated just on the people that were given aflibercept either every 4 weeks or were given 5 initial doses and then every other month, so they're given fixed interval dosing, we learned that the OCT has very little to do with the visual acuity outcome. It has everything to do with should you treat. It's very important, but it doesn't tell you is the person doing well. So we looked at how the change in OCT correlated with the change in visual acuity, either early on at 12 weeks, at 52 weeks, or at 100 weeks. And what this shows us here is everybody above that yellow line, those are the people who improved vision. And everybody to the left of the vertical line, those are the people whose OCT central subfield thickness got thinner. And as you might expect, from baseline to 2 years, we see that most people are in the upper left. Most of the people have gotten thinner and their vision improved, but there isn't a one-to-one correlation. It's not a good correlation. This is what we call, this is like shotgun. It looks like pellets are all over the place on that curve. If you said, for people who decreased by 250 microns, for each individual, some of them lost vision. They're below that line. Some of them gained 5 letters. Some of them gained 10 letters. Some of them gained 25 letters. For each person that perhaps had a change in vision of 20 letters from baseline, some of them decreased by 600 microns. Some of them decreased by 500 microns. Some of them only decreased by 100 microns. Some of them even got thicker. So there isn't a good correlation. There's a correlation, but not a good correlation. The R squared of 9% on this plot tells us that for all the people that you have change in vision, the change in OCT accounts for only about 9% of why their vision changed. 91% of that change in vision is determined by other factors independent of the change in OCT. So the change in OCT does not predict those sort of changes. And we can see that this is also true if we look not only at 100 weeks, but at 52 weeks or at 12 weeks. For each 100 micron decrease, there is an improvement in vision, but it's only 1.2 letters. So that it doesn't predict what's going to happen to the vision. Some people improve 10 letters. Some people lose 5 letters. The average is 1.2 letters. But using this regimen, by treating every month for the first 6 months and then withholding treatment and only treat if it's worsening thereafter on OCT or visual acuity and withhold if it's stable, that does decrease the number of injections. This looks at protocol I from the network, where the vision remains stable through, if you look at the x-axis, 5 years. And there were a median of 6 injections in the first 6 months, but then a median of 3 in the second 6 months, a median of 3 in the second year, 2 in the third year, a median of 1 in the fourth year, and 0 in the fifth. So even though the median number of injections goes down, the average vision remains elevated. Now, these people were monitored at least every 4 months. So everyone was monitored. If they improve, resume treatment. If they worsen, resume treatment. And if they're stable, withhold treatment. And that led to decreased number of injections without a decline in the vision. If you did this in neovascular macular degeneration, you would be more likely to lose vision. Now let's look at what we learned in Protocol T when patients were followed through 2 years, but then they were left to the doctor to decide how to follow them. They weren't systematically followed like in that previous protocol I just showed you, in Protocol I, they weren't systematically followed through 5 years. Not everybody could participate in the Protocol T extension study where we brought them back once at 5 years, but some of them did, so it gave us some information. We can see that about 70% got at least one treatment, but there was 30% that got no injections, and there was great variability of how many injections they got between years 3 and 5. Some got 2 injections, some got 4, some got 10. The median number was 4. Now, if you look at what I just showed you, the median number of injections out to 5 years in Protocol I, that was only 3. So it's the similar number of injections. But if we look here, what we can see is that there was a gain out to 2 years, but then a decline between years 2 and 5. So these people were not systematically followed. What we can see here is even if we break it up by anti-VEGF agent, what we can see is that unfortunately, we still have a decline going on with these people, regardless of the agent, of aflibercept, bevacizumab, or ranibizumab. And even if we break it up into the cohort that was 2032 to 2040, or the cohort that was 2050 or worse, that's what we saw. Now I'm going to take a 1-minute break here, and I'm just going to come on. I just want to bring these other slides on, but just hang on for 1 minute. I'll be right there to continue. And then okay, let me continue if that's okay.
Absolutely.
All right, here we go. So that was how the baseline visual acuity when it's 2032 to 2040 or 2050 or worse influences how we're going to treat it. Doesn't matter which agent you use, 2030 to 2040, it does matter 2050 or worse. And now let's look at what if you're able to monitor people just as they develop edema and treat them or observe them when they're 2025 or better. This was published just a year ago. And this was Protocol V from the network that said, what do you do about edema? It involves the center, so it's not a lot, but they're 2025 or better. Should we just extrapolate from those previous trials and say it works for 2032 or worse? Let's use it for 2025 or better. Should we just start with laser and only add anti-VEGF if the vision starts to drop? Or should we observe and only add anti-VEGF if the vision begins to drop? That was the question, to see if one of these was superior to the other. Let me talk about how it was done if you were observed or you applied laser and only added anti-VEGF if they dropped, because many people now consider that as a viable option. So people were 20/25 or better. They had center-involved edema, and if you just observed them or you added laser, we would see them back in 2 months. Either way, observed or laser, see them back in 2 months because their vision's good. And we ask ourselves first, did the vision drop? A drop in vision is 10 or more letters, 2 or more lines at one visit, or 1 to 2 lines, 5 to 9 letters at 2 consecutive visits that are at least a month apart. And if the vision dropped, if they met those criteria, we start anti-VEGF. And in this case, we started it with aflibercept. So you could observe them and they come in 2 months later. If the vision drops, as we define here, start anti-VEGF. But if the vision doesn't drop, we don't start anti-VEGF, but we look at the OCT. And if the OCT got worse, we don't treat. The OCT got worse because the vision didn't get worse. If the OCT got worse, we just decrease the follow-up to as little as a month's time. But if the OCT is the same and the vision is the same, we just follow them up at 4 months. And we keep going every 4 months until the vision drops, we start aflibercept, or until the OCT worsens without the vision dropping, we don't start aflibercept. In that case, we just decrease the follow-up, maybe from 4 months to 2 months. But until the vision drops, we don't treat. And what we learned is that one strategy is not superior to the other. You could just start with aflibercept, and the primary outcome since they started 20/25 or better was just a little worsening, 5 or more letter worse. Because if you're 20/25, we don't want you to go to 20/32. Or if you're 20/16, we don't want you to drop to 20/20. But most of the vision that dropped was just 5 letters. So that we can see here that that happened to the same percentage that started with aflibercept, or that got laser and started aflibercept if the vision dropped, or got observation and started aflibercept if the vision dropped. Not one strategy is superior to the other. And as I said, most of this was 5 to 9 letter loss because only 10%, 7 to 9% really lost 10 or more letters, and less than 5% lost 15 or more letters. And usually that might be going from like 2012 to 2025. If we look at the percentage that were 20/20 or better at 2 years, this was a predefined outcome. We can see that it was slightly better for aflibercept than for laser or observation, but that was the only outcome that had aflibercept to start with being superior. The rescue treatments with aflibercept still had the same percentage, about 85%, that ended up 20/25 or better. And now let's come back to the whole theme of the discussion here. Why do we consider trying to identify people when they first develop edema? Because if you can follow them while they're 20/25 or better and only start treatment if they worsen, you have 85% that end up 20/25 or better. Remember, I showed you if you're 20/50 or worse, 45% end up 20/25 or better. That's good, not as good as 85%. And if you get them at 20/32 to 20/40 and you start treatment right away, 75% are 20/25 or better. That's good, but it's not 85%. So the strategy should be find people with diabetes, begin to monitor them annually with an OCT to find when they first develop edema and don't treat them, but follow that edema until the vision begins to drop and treat them as soon as it begins to drop. Or if they walk in at 20/32 or worse, you'd have to treat them then. The median number of injections when you do that, and they're 20/32 or worse, is 14, 9 in the first year, 5 in the second year. But the median number of injections, if you catch them when they're 20/25 or better and just use it to rescue, it's 8 injections over 2 years. So you use less resources to treat these people. Or even if you just start with aflibercept when they're 20/25 or better, it's 8 injections, not 14 for the median over 2 years. And here you can see that only 35% of the eyes assigned to observation actually worsened. And so 65% never had their vision worsen, even though they had central subfield thickness that was edema. So that tells us we can watch them. And finally, I want to end with some information that was just published last month, and that is managing people that walk in with vitreous hemorrhage that's not clearing, where we typically would manage them with vitrectomy. That was the standard management, and Protocol AB asked the question, well, what if you started managing them with just anti-VEGF, waiting to see if it clears, and if it doesn't clear, then go in with vitrectomy? Or if you see on ultrasound traction detachment involving the fovea, then go in with vitrectomy. So none of these people had traction detachment to start, but they had non-clearing vitreous hemorrhage. They might have traction detachment in an extramacular location, but not threatening or involving the fovea. So it could be something like this on the right, where there's vitreous hemorrhage there, or something like this on the left, where there's some traction detachment nasal to the optic nerve. And do you have to always go in with vitrectomy, or could you start with anti-VEGF? And what we learned in looking at this is that you could consider either as alternative therapies. So the design was they had to need intervention, but you either go in with vitrectomy and put in PRP at the time of vitrectomy, or you start with aflibercept only. And the outcome would be, what's the area under the curve at 24 weeks? We know the vitrectomy eyes might improve right away, but over 24 weeks and then over 2 years, what's the outcome going to be? And so we had good follow-up to 24 weeks and good follow-up to 2 years. And you can see here that most of the people, the vitreous hemorrhage was there for less than a month, but some of them had it for longer. And you can see here the vision started bad, 2200 to 2250. And what you can see here is that in the aflibercept group, about 30% might end up with vitrectomy, but not necessarily in the first 6 months. It might happen between 6 months and 1 year, or between 1 year and 2 years. But about 30% would indeed eventually need vitrectomy. But that means 2/3 never needed vitrectomy, so that they may not have to go to a center where the vitrectomy is available. What you can see here is that about 1/3 of the vitrectomy group needed aflibercept for some edema at some point. So both groups would need the alternative therapy at some point over 2 years in about 1/3 of them. Oh, and I just wanted to say about 9 injections were given in the group that started with aflibercept to get the outcomes that we saw. Now, what we saw was for the visual acuity, at 6 months, it was no different between the groups. It was a little better in the first 4 weeks for the vitrectomy group, but only at that time point. At 12 weeks and at 24 weeks, the lines are nearly on top of each other. So there's a difference, a minimal difference that is driven by what happens at 4 weeks. Between 6 months and 2 years, still no difference. They all end up the same. So you could start with vitrectomy, and that person's clear at 4 weeks, but their vision's no different than if you just started with aflibercept, where 1/3 of them would need vitrectomy eventually, but 2/3 don't. So if it's just their first eye, and the other eye is good, maybe they can wait the 4 weeks, and then the lines will be on top of each other, depending on which strategy you took. If the other eye isn't good, maybe you want to go in right away so they don't trip down the stairs by not having vitrectomy. So there is a difference in the vision at 4 weeks in terms of who's 20/32 or better, maybe a little difference who's 2200 or worse. But by the time we're out to 6 months, no difference for good vision or 2200 or worse. And by the time we're out to 2 years, no difference for good vision, maybe a little worse for the vitrectomy group at 2 years that had prompt vitrectomy. Only 1/3 of the aflibercept group got vitrectomy. In terms of following these people, you still have to follow them. You can't do the vitrectomy and send them home, because about 25% of them will still get edema with vision loss in the center that needs treatment, whether they get vitrectomy to start with or they get aflibercept to start with. And there are very few ocular adverse events that we see here, and they're similar in both groups, except this traction retinal detachment, where we see it more often with the aflibercept group, but that's not new traction detachment. That might be uncovered. As the vitreous hemorrhage clears, you see the traction detachment along the arcades, perhaps, not involving the fovea. And you can see that that difference didn't lead to worse vision in the vitrectomy versus the aflibercept group. In fact, the aflibercept group had better chance of avoiding 2200 or worse at 2 years. And so we learned that if you have vitreous hemorrhage that's not clearing, you could go in with vitrectomy or you could go in with aflibercept, that these are each good alternatives. If it's their first eye, you might have the luxury to wait 4 weeks, and then there's no difference thereafter. If it's the second eye, maybe you want to go in right away before they lose vision. You get quicker improvement in vision in the eyes assigned to vitrectomy. But from 24 weeks through 2 years, no difference. So if you can wait just a short period of time, you might want to start with aflibercept. Still, if you start with aflibercept, 1/3 will need vitrectomy. So this is what we've learned. We want to base our management of DME based on initial visual acuity. If it's 20/32 or worse, consider managing them with anti-VEGF. If it's 2032 to 2040, you'll have a median of 14 injections over 2 years, and just choose whatever anti-VEGF agent you have access to, depending on the individual patient's circumstances. Maybe they're about to need cataract surgery. You might want to get rid of the edema faster. That would happen with aflibercept over bevacizumab. Maybe not, and then bevacizumab's just fine. If they're 20/50 or worse, they will get clinically relevant, definitive, greater chance of ending up with better vision if we start with aflibercept. When it's 20/25 or better, there's a median of only 8 injections, not 14, and you can observe. Or you could start with aflibercept, or you could start with laser. And that's what we've learned, and I look forward to answering some questions maybe for 10 minutes here. And what a pleasure to join all of you and share with what we've learned about treating diabetic macular edema and a little new stuff on vitreous hemorrhage as well. Thank you very much.
So thank you, Dr. Bressler. That was a very interesting talk. And I had a couple of quick questions for you. One is that in cases in which you used, in cases of vitreous hemorrhage in which you used aflibercept, do you attribute any of those, fall in vision to, the crunch phenomenon? Did you see the crunch phenomenon in any of those cases? And my other question is that...
let me answer that first, because I'll forget. Well, we didn't. So that crunch phenomenon probably is with eyes that already have traction detachment involving the fovea, perhaps in ROP, for example. And so if you're going to put in anti-VEGF right before you do a vitrectomy, it should be in eyes that don't have traction detachment involving the fovea. Or if you do put it in, you want to go in with that vitrectomy within the next day or so. So we don't see a crunch phenomenon in eyes with extramacular traction detachment, in eyes with vitreous hemorrhage, in eyes with proliferative retinopathy and no vitreous hemorrhage. We don't see it. It happens in eyes where there's traction detachment already involving the fovea if you wait a week or two or you wait too long before doing the surgery.
Right. So my second question to you is that in cases in which you use, so akin to the fluid study for AMD, do you think that, like for a country like India, in which patients have a monetary issue, so can we tolerate some fluid, and can we reduce the number of injections from 6 to, let's say, lesser number of injections, like akin to the fluid study for AMD?
Yeah, not in the first, not in the first 6 months, because you might save on some injections in the first 6 months, but you might end up doing more injections for the rest of the person's life. Remember, we showed a median of 14 injections over 2 years if you use that approach, but people end up with excellent vision. We don't know if they would end up with excellent vision if we start withholding in the first 6 months. You could try it, but we just don't know. We also know that if you can, with limited resources, if you can concentrate on catching the eyes just when they develop edema, if you catch them when they're 20/25, not only can you tolerate fluid, you can tolerate thickening, because I showed you that for 2/3 of them that were in the observation group, they all had thickening, but their vision did not decline where you had to intervene. So you want to catch those. And if you do have to intervene, it was a median of 8 injections over 2 years, not 14. This is great when you have a lot of resources or limited resources. So I wouldn't start trying new regimens because we just don't know if they're going to work. Obviously, if you don't have anti-VEGF, laser is a very good treatment. But if you have anti-VEGF, this is how I would use it. And if you don't have aflibercept or ranibizumab and you have access to repackaging bevacizumab, this is how I would use it.
Did you see any drying or atrophy with so many number of injections? Do you ever see drying or some atrophy because of the use of anti-VEGF?
While we do see it, we don't think it's related to the injections, because we have people who got, as I said, not just an average of 14 injections, but an average of maybe 28 injections over 4 years. And if you catch them early, they're still 20/25 or better. So in the few eyes that did not have good vision, it would be either because a macular hole developed, as can happen in anybody, or a central vein occlusion, both in the control group and in the treatment groups, but not due to atrophy. So we don't see atrophy developing in DME following anti-VEGF. We do see atrophy developing in DME, but not at an increased rate compared to a control group. In macular degeneration, we do see atrophy developing, but that's part of the natural history, not necessarily the anti-VEGF, but the natural history of having drusen or having choroidal neovascularization and scarring. The natural history is for the pigment epithelium in many of those to atrophy.
Thank you.
Dr. Bressler, thank you very much for being here and sparing your valuable time. It's been a long time since we met.
Great to see you again.
very sweet of you to, without any hesitation, to participate in a conference like this right across continents. So sweet of you. And let me tell you, friends, he's a wonderful human being, a great family man. I just wanted to say a few things about him on a personal level. Always smiling, always there for his fellows, and otherwise, he sets the standards for diabetic retinopathy norms in the world. And when he says, this is it, that's how it is. And so wonderful. And he does that with a very smiling face. And he's always got his fundamentals so clear. This is it, not this. And he's absolutely clear in what he says. There are no dichotomy in what he says. And that's the best part about him. So nice of you to be here with us, Dr. Neil, and spending your valuable time early morning out there with a busy OPD. How is the OPD nowadays with the corona scenario? I mean, do you schedule your appointments?
Yeah, so what we did was, before any vaccinations were available, we divided what we had. We had 4 physicians on one floor, and we broke that into 2. And we started them earlier, and we ended them later. And so the 2 physicians took over a broader area so that there were no waiting rooms. So people just walked right in. If they had to go to get imaging, they walked right over to imaging and then back into the room. Anything that we could do to avoid having them interact with more people. Because you have to treat most things, retinal detachments can't wait, endophthalmitis can't wait. We really, ended up at about 85% of our normal volume. We don't see a lot of like just drusen follow-up or brain follow-up. That's a lot of our comprehensive ophthalmologists, and their volume went way down because things were just held off, as you saw. But by and large, that's what we did. Our staff were quite concerned, and we tried to be as empathetic as we could for them because they were very worried. They weren't really in school. They were trying to learn from home, but who's home to be with them? So there was a lot of potential stress for them, but they all did their best. And we were able to get about over 85% of the staff vaccinated right away within about 2 months. And so that helps because their level of stress goes down. The ones who didn't refuse, they might be pregnant and they were waiting, or they might have some immunocompromise that says, well, let's wait first before you do it. So we had a very good uptake on that. And now we've been able to get about 85% of the people over age 70 to get vaccinated. And now we brought that down now to 70 and 60. And it's just probably another 2 or 3 months that will open it up to everyone. And the question will be, will we be able to get over 70, 80% when we open it up to every adult, over 18? I don't know, but certainly the older people were more than willing to get vaccinated. And the rollout, has really increased. We're doing about almost 2.5 million per day. And I realize our population is a quarter of your population. So you'd have to do 4 times that to go at that rate, plus other logistical issues that you have. But I would say overall, we had the worst death rate in the world. It shouldn't have been, but it happened for multiple reasons. It's very sad. But I think we're going to have rapid correction for vaccination. And then we'll have to watch the variants. Nobody can determine what will happen with that. And have everybody work together around the world on this. It's a world problem for everybody.
So did the injections continue at the same rate? Or,
yeah, by and large, they did. We would call people and tell them, we think it's as safe for you to be here as anywhere. Safer than the grocery store. We know how to bleach. We know how to mask. We know how to, do it for them. So we would have to talk to some of them, and we called up each and every one. So our staff were not working as much on other projects, in cataract or, in refracting people or whatever. So we had them call each and every person that needed to come in to reassure them, to answer their questions. And I think that helped a lot. Not 100%, but 85%.
Well, actually, we learned quite a bit from both of your talks. The second talk was more illuminating that AB study. I just wanted to ask about your views on steroids, because DME is thought to be a multifactorial. Apart from VEGF, there's a lot of inflammatory component also. About your personal.
Yeah, it's a good question. So first of all, if you look at the regimen I showed you, we showed you that following that regimen, if you're 20/25 or better, 85% end up 20/25 or better. It's tough to improve on that. It's darn tough. And if you're phakic and you induce a cataract, it's even worse. But if you're 20/32 to 20/40, or you're 20/50 or worse, and you've reached a point of stability, first of all, it takes a year to get to that stability, right? Because you do 6 injections. And then if there's still edema, not everybody has edema, but if there's still edema, then you might add laser, and then you might resume if it comes back until it reaches stability again. I think if you have somebody who's phakic and has stable edema, you don't want to touch them. because you're going to induce cataract in most of them. They have stable edema, so you're going to give them more than one shot of corticosteroids, and you'll eventually have to remove a cataract. And removing the cataract in the presence of persistent edema often does well, but in about a third of the cases does not do well. So what we do is we consider corticosteroids, but only in those cases that have gone more than a year, as I said, with these injections and laser, and they still have stable edema and they're pseudophakic, and they have to have some vision loss. They have to be 20, 32 or worse. We're not going to do it to someone who's 20, 25. And they have to have areas that we could laser. It might just be a central cystoid that's left. We're not going to laser that. So it ends up being a few people, but that's very few because they have to be pseudophakic. It has to be persistent. It has to be 20, 32 or worse. There have to be areas to treat. And that just gets to very few people. So yes, I think it's worthwhile, but in very few people.
And the other pertinent question was, a lot of these DME patients have coexisting cataract. So you want to stabilize DME first, then take on cataract? Or
yeah, ideally. No. So you have to see how badly they need the cataract out. If they have both eyes are bad, they can't wait too long. And so then I would use aflibercept if you have access to it. That has the fastest rate of getting rid of the edema. And you don't want to do the cataract surgery if you can help it when there's edema, but you can't always help it. So sometimes you have to remove the cataract in the presence of edema, but you try to avoid it. You may have to tell the person, oh, you have some cataract there. We're going to take it out next year, and we're going to work on this edema until then. So we've got a long time to help you, but that's because we want to help your vision forever. 3 months, but forever. And so that's why. But I'll tell Dr. Himanshu, it's, these are advice and guidelines. It shouldn't be so absolute. This is what we've learned, and then you apply it each and every patient differently. Absolutely.
A question, Dr. Neil. Quite often we have found quite a few diabetics who had background diabetic retinopathy, and you do a cataract and they get into a florid state. Such diabetic retinopathy precipitates. Would you advise which are the candidates who might get in for that? Because the cataract surgeon takes the blame for this. Would you? So
certainly the ones who have edema. The ones who have edema are at risk. The ones who had had edema in the past, they're at risk too, because maybe you did laser or you gave them anti-VEGF. So you want to watch both of those groups very, very carefully. If they had it or they have it at the time, see them like 2 to 4 weeks later and jump in with anti-VEGF as soon as you can if you see it worsening in any way. The ones who haven't had edema, it's very unlikely. If they don't have a history or they haven't had it, it's very unlikely. That's good. They may get it a year later, which is part of the disease, but not because of the inflammation associated with the cataract surgery. And we don't find that adding corticosteroids or adding any drops is going to overcome the people that are at risk. So what you do is get rid of as much edema as you can, hopefully all of it, but watch very carefully the ones who had it or the ones who have it at the time you're doing the surgery and jump in with anti-VEGF right away. If they're pseudophakic after a year and it's not gone, you could jump in with corticosteroids as well, but not right away. You want to give the anti-VEGF a chance. It doesn't always happen after 1 or 2 injections. It sometimes takes 6 with laser on top of it.
Neil, what do you advise to a patient who has, uncontrolled parameters, HbA1c and blood sugar is haywire, but
very important.
In a very severe edema? What do you advise?
Very, very important. So I'm not talking about the person who's in the intensive care unit with, fluid overload or something, but the people who are in bad control and are ambulatory. You want to get their control as good as possible, but in parallel to treating the vision. You don't have to wait to get things in control to treat the retina. You treat the retina in parallel to trying to get them under better control if you can. There's no need to wait. These drugs are so powerful. These agents are so powerful. They overcome whatever, you're going to get the hemoglobin A1C from 14 to 12 to 11 or something. Anyway, that's what we think. Now I'm going to have to go. I apologize. And it's late for you all too, but really because I have to get to our next meeting.
Thank you so much. Thank you so much for coming and joining us, sir, and giving such
Thank you all, really. Always
nice.
A pleasure. I look forward to seeing you over there. Okay.
Yes. See you soon.
Okay, bye-bye.
Okay, see you all soon. Bye-bye, everybody. Thank you. Bye.
Thank you so much.